Have some in my personal inbox. So the first question I have is Sugamadex available in Bangladesh?
As I'm saying, it will be available very shortly. I am talking to a vendor who will bring the Sugamadex, and the price will be for a single dose will be something around 2,500.
Okay, so I have another question which says that in case, since rocuronium is not available everywhere, and if we use saxamethanium in a patient of burn who presented within 24 hours, how can we proceed with that? And if we can manage to have rocuronium, and do we use RSI to intubate that patient? I mean, with cricoid salix maneuver.
I think for a burn patient, it's always useful to use rocuronium to avoid saxamethanium, as the burn patients have the imbalances of its calcium and potassium levels. So it's always useful. Saxamethanium is not indicated in those cases. If we have rocuronium, we should use rocuronium in those cases. And for RSI, of course, we can use the normal, whatever we use, the cricoid pressure and everything.
Can I ask you a question, please?
Sure.
Yes, sir.
Just a simple question, because this will be a clinical question, because as we know, there is a big difference in sensitivity between adults and children as regards muscle relaxants are concerned. So can you just explain from scientific basis why this difference? I think that will be useful for the students and trainees. Why the response to non-depolarizing muscle relaxants are different? Why the pediatric patients population are more sensitive to non-depolarizing muscle relaxant than their adult counterpart? I think if you can just explain on a scientific basis, please.
I think this is due to the receptors problem, as I have mentioned that in the children, in the fetal receptors are
epsilon.
Fetal are gamma, sir. Epsilon is that.
Epsilon, I think you are talking about the fetal gamma, but some of them turn to epsilon later on.
Right. And this receptor gamma, this receptor protein may be responsible for the different actions in the children and in adult. And also H factor, as I said, the metabolism of the drugs may be another cause. In children, that metabolism and the adult metabolism differs in some section. But I think the main thing is gamma receptors and the epsilon receptors.
Okay.
I just want to make a comment on the presentation. I think before it's too late. The comment is that I think Lutful Aziz has done a good job in spite of undertaking a very huge task. I think he has done very well. The important thing that I think you probably should know, that on this particular area, that is neuromuscular junction, there are 2 Nobel Prizes awarded on 2 occasions. One of them is our known Bernard Kazi, who got his Nobel Prize on re-entry or the recycling of the neurotransmitters in that NMJ. And other one is in 1957, when saxamethonium was introduced as a depolarizing agent. I don't remember the name of the gentleman who got it, but that's another Nobel Prize given. That's one thing. And the other is here that the Sugamadex is probably is what we need at the moment, but it has got a big but. That it is expensive. That's a very big but. On the other hand, it works better on the steroids, steroids, that is.
Absolutely. It's
And
not better, so it only acts on steroid.
It binds to the steroid molecule. On the other hand, the other group, the other counterparts, the atracurium group, the cis atracurium and other, the whole lot, they will not be benefited.
Absolutely.
Benefit at all. So it has got its little bit of problem. But on the whole, I think this is something we must be looking forward to. That's all I wanted to say.
That's the reason the calabedion to the
that's right. That's the other one.
It acts on both groups of drugs.
Even the one you call CW002 is also called AB002. So they are better on that aspect, but they do not bind only steroid. They also work on the
isopolynion group.
That's right. They are competitive blocker on that. Yeah. So there you are. Thank you very much for a very good presentation, Lutful Aziz. It's great to be here for me, and I'm sure Jahangir is enjoying it too.
Yes, sir. Thank you very much. Still, I'm enjoying. That's true, but I would have been more happy if things would have been more clinical, because more of we people, the anesthetists, are working on clinical aspects, and our experience is from clinical point of view, even though that there is a pharmacological basis or scientific basis of muscle relaxants. But we would expect Dr. Lutful Aziz will be presenting another lecture on clinical aspects of neuromuscular blocking agent. I think that will be more useful for the clinicians, because there are a lot of questions to be asked on that ground, because
that could have been done, but
do you want it back to back?
Can I?
Jahangir, do you want it back to back? I mean, he can do this next week.
Yeah, I think so. Because sir, because there are a lot of clinical questions to be asked. But today's lecture was mostly on a pharmacological basis, so I think this is not the place to ask those questions. So I think if we can deliver another lecture on clinical aspects of muscle relaxant, I think that will be more useful.
I can also do that.
Lutful Aziz, you try to do that next week when things are hot, you see. Otherwise, once it's cooled down, you'll have all the trouble of starting all over again.
Thank you so much for such a wonderful presentation, Dr. Aziz Bhai. Can I just ask one clinical question, if it's okay with you? Basically, it's about reversal. I personally prefer not to reverse a patient if I can, but there have been a lot of papers that say that it is imperative. Sometimes they say it's almost imperative that you should reverse patients even if you have all train of 4 twitches over almost 100%. And part of it is something to do with the ciliary clearance and lung function. And they have also gone to the point to say that if you don't reverse patients, they may have an increased chance of getting basal atelectasis with pneumonia. Do you have anything to say on that?
This controversy is always there. This controversy is absolutely present, because there's a school of thought that the reversal is not always required. If your monitoring is perfect, then you don't have to require it. If the TO4 or double burst, whatever you are seeing, and if they are all required, you don't require, because in case of anticholinergics, if you give them without any requirement, then you are producing the side effects of all those drugs. But at the same time, the problem is with what kind of drug that we are using. Actually, if we are using the recently developed drug, that is, it's not recent anymore, rocuronium. If we are using tibecuronium, if you are using pancuronium, the reversal is actually required, because the chances of recurrization or PORC is very high with those drugs, even if the monitoring is there. Because we know that the TOF4 is, if it is 70%, then we feel safe to extubate the patient. But with those 30% receptor blockage, the chance of PORC are always there. But with rocuronium type of drugs, the reversal is actually, they don't require reversal because rocuronium are so less, duration of action is so less because it metabolizes so rapidly within 15, 20 minutes, 25 minutes. And the chances of recurrization with rocuronium is seen very less. So even without reversal, the chances of recurrization with rocuronium is less than those of pancuronium or pipecuronium or drugs like those. So depending on the type of drug that we are using, the reversal is also dependent on that, the type of drugs and the type of monitoring that we are doing actually.
Thank you.
Thank you, sir. So we have some more questions. If Sugammadex is not available, should we be using rocuronium, sir? That's one of the questions.
Rocuronium is a safe drug, but if we are absolutely sure about ourselves and if we are sure that the patient can be intubated with our preoperative checkup and everything, and what we actually do in the case of using rocuronium, we actually do it. This is, of course, the teaching of Iqbal sir here. We first sedate the patient with propofol and everything, then we do actually mask ventilation. And if the mask ventilation is possible, if we can feel that the mask ventilation is possible, we can safely use rocuronium and we can use 3 into ED95 rocuronium and we can intubate the patients in 90 minutes. And if mask ventilation is possible with only sedation, then it is the problem with rocuronium, not intubate, not ventilate possibility is very less. But if the mask ventilation is a problem, then we should be very careful. And if our preoperative assessment, we think that the tracheal intubation would be difficult, then we should not go for rocuronium, of course.
Okay, sir. Thank you, sir. There's another question, which is it justified to use different non-depolarizing drugs in a single case?
This is again a difficult question. We should, in clinical aspect, if we are using the same type of drugs, like if we are using rocuronium and vicuronium, we can safely use that. There will be no problem. But if we are using two different, structurally different drugs, that is rocuronium and intratracheal or atracheal, there might be some difficulty. There might be some difficulty in their duration, in their action. So it is not usually recommended to use different kind of structural drugs in the same case.
Okay, sir. Thank you. So,
can I ask a question, sir?
Yes.
Sure.
Go ahead.
Thank you, sir. Firstly, আপনার elaborate presentation এর জন্য অনেক কিছুই ভুলে গিয়েছিলাম, সত্যি কথা বলতে আবার রিক্যাপিচুলেট হতে অনেক কিছুই ক্লিয়ার হয়েছে স্যার। জাস্ট একটা কোয়েশ্চেন বলতে স্যার, আমরা মানে যখন ট্রেনিং ছিলাম স্পেসিফিক্যালি, তখন বিশেষ করে আমরা রোকিউনিয়াম নিয়ে অনেক স্টাডি করতে চেয়েছিলাম। তখন একটা কোয়েশ্চেন অ্যারাইজ করেছে যে হেলসিঙ্কি ল অনুযায়ী আমরা হচ্ছে রোকিউনিয়াম নিয়ে কোনো কাজ করতে পারবো না, বিকজ উই ডোন্ট হ্যাভ এনি সুগামেটিক্স ইন আওয়ার কান্ট্রি। সো ইজ দ্যাট ট্রু স্যার, অর আমরা কি কোনো কাজ করতে পারবো রোকিউনিয়াম নিয়ে ইন অ্যাবসেন্স অফ সুগামেটিক্স?
Sugammadex is a very recent development. So, but rocuronium came much before Sugammadex. So, rocuronium নিয়ে যত কাজ হয়েছে, রocuronium-এর যত স্টাডিজ, যত ট্রায়ালস হয়েছে, সব কিন্তু Sugammadex এর আগে। কাজে আমার মনে হয় না যে রocuronium নিয়ে কাজ করার কোনো বাধা আছে। হ্যাঁ, এখন Sugammadex না হলে রocuronium নিয়ে কাজ, রocuronium না, ইনফ্যাক্ট মাসল রিল্যাক্সেশন অ্যামাইনো স্টেরয়েড গ্রুপ নিয়ে কাজ করতে মানা করা হচ্ছে ফর দ্য সেফটি রিজন। বাট এগেইন এথিক্যালি চিন্তা করলে হয়তো এটা একটা বাধা হতে পারে, বাট নর্মালি আমরা যে আগে যে কাজগুলো করেছি কিংবা ফেজ ট্রায়াল কিংবা নর্মালি রকুরোনিয়ামের উপরে যত ক্লিনিক্যাল ট্রায়াল হয়েছে সব কিন্তু সুগামাডেক্সের আগেই হয়েছে। কাজেই রকুরোনিয়াম নিয়ে ট্রায়াল স্টাডি করার আমার মনে হয় না কোনো ভালো। আর সুগামাডেক্স আমাদের মধ্যে চলেই আসছে, কোনো অসুবিধা নেই, তারপর তো আমরা ইমিডিয়েটলি করতেই পারি।
সুগামাডেক্স না থাকলে সমস্যা কি? আমরা তো
সমস্যা সেফটি, আর কিছু না। সমস্যা
সেফটি বলতে কি, আমরা যদি রিভার্স করতে না পারি, আমরা যদি ইন্টিউবেট করে রেখে দেই পেশেন্টকে, একটা সময় একটা পর তো
না না, খালি রিভার্সাল না তো, এটা হচ্ছে যে ইন্টিউবেটই যদি করতে না পারি তাহলে কি হবে?
এলএমএ দিয়ে রেখে দেব।
স্টাডির মেইন
নো,
এলএমএ দেয়া যাবে।
নন ভেন্টিলেট নন ইন্টিউবেট পেশেন্টের সময় অনেক সময় এলএমএও দেওয়া যায় না, কারণ মুখই খোলা যায় না অনেক সময়, যেই কাজগুলো হয়
মেডিকেল ইস্যু। As long as Sugammadex is available, that's why it may be a medical legal issue, nothing else.
লুৎফুল আziz যেটা বললেন যে সুগামাডেক্স আসছে কে বলে, এর আগ পর্যন্ত তো সবকিছু হয়েছে, তাই না?
That's why that time it was legal. সেই সময় তো টিউবোকুরারিন দিয়ে কিডনি ট্রান্সপ্লান্ট ও লিগ্যাল ছিল।
জি স্যার, বাট এখন যেহেতু এটা চলে আসছে, আমরা মনে হয় এটা,
আমার মনে হয় এমন কোনো হার্ড রুল থাকা উচিত না এবং দরকারও নেই আমার মনে হয়।
এটা থাকলে ভালো, অবশ্যই সেফটির জন্য বলা হয়েছে। এখন আমরা যদি রিকোয়ার্ড অ্যামাউন্টের মধ্যে রকুরোনিয়াম, আমরা যদি এখন রকুরোনিয়ামের হাই ডোজের উপরে কাজ করতে চাই কিংবা আমাদের পেশেন্ট সিলেকশনে কোনো অসুবিধা হয়, তাহলে অবশ্যই আমরা খুবই খারাপ কাজ করবো উইদাউট সুগামাডেক্স। বাট আমরা যদি রিকোয়ার্ড অ্যামাউন্টের মধ্যে ED95 3x ED95 এর মধ্যে কাজ করতে যাই, তাহলে উই ক্যান ম্যানেজ।
থ্যাংক ইউ স্যার। স্যার উইথ
সুগামাডেক্স চলেই আসছে, আমাদের এই প্রবলেমটা
মেনশন ওয়ান থিং।
হ্যাঁ, জাস্ট আমি স্যার পারমিশন নিয়ে এটাই চাচ্ছিলাম যে ফেরদৌস ভাইকে আমি একটা কোশ্চেন করতে চাই। সো হ্যাপি টু সি ইউ अगेन। যে জাস্ট সাথে থাকার জন্য অনেক বেশি থ্যাংক ইউ আপনাকে। এবং আমার সাথে একটা কোশ্চেনও ছিল এই কারণে যে ওখানে আপনি ইউকে তে মানে কি ইউজ করছেন, অর ডিউরিং ইনটিউবেশন অর হচ্ছে মেইনটেনেন্সে কি মাস্টার রিল্যাক্সেন্ট আপনাদের প্রেফার করা হয় এন্ড ওয়াই?
It depends patient's clinical condition related to the muscle relaxant. We have all the muscle relaxant, like we're using the rocuronium, we're using the cisatractinum, we're using the tractinum. It depends again with the clinician's preference. It's always. But the thing is, for reversal, we're not using the rocuronium muscle relaxant. Always the Sugammadex. We are using the Sugammadex for rescuing. When sometimes we are giving the rocuronium, but surgery is all of a sudden finished within 15 minutes. That is expected. It was that it will take 60 minutes. Then we can use these Sugammadex. But again, in terms of cost, NHS is also about thinking that how much resource we are using. So. And we need to sign special books that I am using this Sugammadex for this reason. So it's not a clean sheet that I can use Sugammadex always. So I have to clarify sometimes that what the reason I have used this Sugammadex, because it's around £60 cost if I'm using the 2 milligram, but it's more than the 4 milligrams, so this is double cost. But we can't forget one thing, that always when we were using the muscle relaxant and can't intubate, can't ventilate scenario, so we have the option of front neck access. So we can't forget our basic. So basic is front neck access, because it will take some time to get the Sugammadex from your freeze, from your storage to give the patient. But when the SATS is going down, if it is going down to 80 to 40, so that time you can't access that Sugammadex, you have to go for the front neck access. So the thing is, we don't forget the basics. Basic is can't intubate, can't ventilate scenario, that is different from the Sugammadex. But if we are thinking that we are reversing the patients very quickly, the Sugammadex is the best choice. But you have to keep in mind, this is not a clean drug in that sense because the Sugammadex has some anaphylactoid reaction, and we have a paper that published in the BGA in 2018. There is a series of cases all over the world. There is more than 15 cases of anaphylaxis and anaphylactoid reaction. We don't know clearly what's the reason, but there is the anaphylaxis. So we have to
it cannot be anaphylaxis. It has to be anaphylactoid.
So exactly, but still there is controversy, but definitely when we are using these kinds of drugs,
because if
স্যার আনমিউট করতে হবে।
আর আপনি মিউট হয়ে গেছেন, একটু আনমিউট করে নিন।
Sorry, Nimmi is trying to tell something. Okay.
Oh, no, sir, actually, sir. আপনি শেষ করে দেন, sir, please. ওটা শোনা যায়নি আপনার
I was just saying that this is most of the reported cases are not. They call it anaphylactoid, as you know the pathway of the pathway how the anaphylactoid takes place, as opposed to anaphylaxis where previous exposure to the particular molecule.
Exactly, sir.
Here Sugammadex is not really responsible as an anaphylactic agent.
So that's the thing. So we have to think all of the options ready. But if we have the Sugammadex, that's a great thing that in the operating room we can use for a difficult patient.
Actually, the total scenario has changed for, I think, from 10 years, 20 years back to now, because the difficult intubation kit or the different intubation situation is nowadays is so less, because we have so many good things in our hand, like the laryngeal, the video laryngoscopes, the fiber optic laryngoscopy, the neck, as you said, the neck the front of the neck. So everything is available to us, and everything is available in the theater. So the conditions of can't ventilate, can't intubate situation, we can manage it much better than before. And we also have Sugammadex, and it's readily available. If it is readily available, then we can definitely use rocuronium, and the drug is so safe, except that in some situation where we cannot ventilate, cannot intubate situation. Apart from that, this drug is safe. This drug can cause the onset is very short and very timely onset, and the duration is also very reasonable, so we can use this drug. And the reversal is also not that we have to reverse with anticholinesterase, or we can go without, if we are monitoring correctly, we can go without reversal agents. And of course, Sugammadex is not required for all the reversals of rocuronium, as you have said. This is true, but again, if the anticipation time is 60 minutes and the operation is finished in 15 minutes, we have to use Sugammadex. We cannot wait for 60 minutes with our patients in the OT table.
Thank you so much, sir, and Bhaiya, of course. আরেকটা শুধু কোশ্চেন ছিল, ভাইয়া আপনারা কি ইউকেতে নিউরোমাসকুলার ব্লক যে মনিটরিং সেটা কি ইউজ করেন রুটিনলি?
Yes. So when you are using the muscle relaxant, we always use the neuromuscular monitoring. So it's a routine kinds of monitoring nowadays, because we have to justify our reversal agent as well. When if it is the twitch is 1, 2, so we need to record the things that how was the twitching level, and what time and what reversal we have used.
What do you use? Top guard or top watch?
Top guard.
Thank you. Sir, I have a few more questions, sir. I'm going to go through them quickly. Sir, when should we administer reversal drug, before or after extubation? Is there any anesthetic importance? I'm sorry, there has been some problem again.
Hello? And whatever we are using, maybe 0.1 mic per kilogram per kg, per kilogram per minute continuous infusion, and almost after induction no relaxant required, almost.
Okay.
This is the beauty of using the remifentanil. When we're using the remifentanil through the TCI for a long procedure, long list, especially in the ENT, thyroid surgery, neck surgery. So that time we're using only the induction dose of rocuronium, and we never use the top-up dose of the relaxant, because the remifentanil with the SIBO or desflurane keeps patient such a steady condition and the vitals are such a stabilized, so patient is not taking any breathe, or patient is not getting the tachycardic, or patient not getting the hypertensive state. So we're not using the other kinds of antihypertensive for doing these kinds of surgery. So it's very good to have these remifentanil during the surgery. But again, in terms of safety, if you have this TCI, that is the best option.
You are very right in the same observation you are, but as long as you are using top guard, definitely it is showing some response that muscle relaxant effect has over, and you are not using. So how do you present in your documentation that top guard showing patient need muscle relaxant, but clinically patient need not? But how you are justifying in your record that you are not giving muscle relaxant?
Ultimately, instrument can help you to take a decision. Instrument not will tell you take this decision. It will help you. So it's your clinical judgment to make a decision what your patient needs.
Again, Shamal, the problem is even if the patient is quiet, patient is not moving, and the top work says that muscle relaxants is the reversal is muscle relaxant effect is gone, but with remifentanil the patient is quiet and you are not giving muscle relaxant. This is okay in some cases, but there is every possibility that the patients will move, or patients will may not be for safer surgery. It's not safe. So even if you are using remifentanil, you should give muscle relaxation.
You must realize that remifentanil or all the fentanyls are respiratory depressant drugs. You see, so these are all narcotics. So without muscle relaxant, the patient may not breathe at all with the use of remifentanil. But it wears off very quickly. That is as Firdaus was saying, there's the beauty of it that it wears off very quickly. Remifentanil is the best in that. Probably L-fentanyl. Do you use L-fentanyl by any chance?
L-fentanyl very rarely. Remifentanil was used sometimes back, but after remifentanil
has stood the test of time, so it is still going on very strong.
Okay. So,
I have a question for the students,
yes,
not
sir.
for the seniors.
Yes, sir.
Can you tell anybody that what are the non-anesthetic use of muscle relaxant for students only?
Anyone, if want to answer the question, have to unmute themselves first.
Let them think and gonna continue.
Okay. Okay, sir.
Continue with the other.
So I have another question, is that how we should manage the anaphylactoid reaction after rocuronium injection? That's another question, sir.
This is
all anaphylactoid reaction, the management is same.
Okay.
all anaphylactic reaction, the
Management is same.
The
Okay.
management is all the same. In my 20 or 25 years of rocuronium use, I have seen only one case where rocuronium anaphylactic. We have seen rocuronium anaphylactic reaction, and the management is same. The management, there's no difference in management of anaphylactic reaction in any drugs for that matter.
Okay, sir. Thank you, sir. So, is there any
Next question.
anesthetic importance of reversal in case of atracurium use? I mean, is there any anesthetic importance of reversal in case of atracurium use?
Shamul can answer that better. Shamul's favorite drug. Atracurium is one drug which is, as we know, that is Hoffman elimination, and that is spontaneously eliminated from the body. We don't actually require any reversal. But for
that is theoretically it shouldn't. But
that is theoretically it shouldn't. It's same as rocuronium. Theoretically it shouldn't. For atracurium also theoretically it shouldn't. But for cis-atracurium, is again something that it is a better version of atracurium. But for reversal, again, you can, the reversal of cis-atracurium and reversal of rocuronium is almost similar. So in these two drugs, it totally depends on the anesthesiologist and his monitoring whether he will use reversal drugs or not.
Okay, sir. Thank you, sir.
Metabolites of atracurium, is it a potent component like muscle relaxant? So far I can remember when
Yes,
you use it for long time,
the
I think it is
metabolites
better.
of atracurium is cis-atracurium, so and is also the other metabolite is laudanum. That's why the atracurium is, and also it's histamine release. So atracurium is not getting any popular nowadays. Cis-atracurium is almost taking all the places of atracurium. So
Yes, sir.
atracurium, yes, even if it is producing cis-atracurium, but the amount of atracurium that you use for a single case is not enough to produce the metabolites that will be difficult to manage or should be reversed. Yes.
Thank you, sir. So, Shamu sir, we have some answers for your question. One has said there is low dose Saxa is used for laryngospasm, and another student have said that electroconvulsive therapy is another non-anesthetic use of muscle relaxant.
But then there is anesthesia in ECT, you see.
Yes, sir. So, if you want to answer that question.
Yeah, that is the botulinum toxin that has muscle flaccid action and used mainly for cosmetic purpose. In some areas, therapeutic purpose also, like chronic spasm. And recently that botulinum is coming in the form of local anesthetic, and which produces analgesia 7 to 8 days. But still the safety margin is under question, so it's taking some time. So botulinum toxin is one of the components which has muscle relaxant property but used as a non-anesthetic drug.
Thank you, sir. So
probably it inhibits the acetylcholine release. Is that way it works?
Okay.
Botulinum works in pre-junctional stage.
Sodium channel blocker.
Okay.
It stops the release of acetylcholine from the pre-junctionals.
Okay.
No more questions, so we can conclude?
No, sir. I think we should conclude. We don't have no more questions.
Okay.
I think it's about 2 hours, Srijan, more than 2 hours.
Yes.
So you must be feeling very tired.
Thanks, Lutful sir. সারা জীবন মনিটরিং খুব ভয় পেতাম, এই সুযোগ আর একটু ঝালাই করে নিলাম। নিউরোমাসকুলার মনিটরিং এর শুনলেই আমি দূরে দূরে থাকি।
মনিটরিংটা খুবই সোজা, মনিটরিংটা করা। Anyway, thank you very much, everybody.
Thank you, sir.
This will continue, and our next lecture will be on August 5 after Eid. আমরা ঈদের জন্য একটা break নিচ্ছি. So August 5 will be our lecture on obesity and anesthesia by Dr. Akhter. And
okay.
If I can prepare, or if I can have enough courage, I'll try to take the clinical implications of muscle relaxation on 28, but that is not sure. Thank you very much.
Thank you.